this topic is not very much covered because we don't have access to these specialty lenses everywhere. We are going to cover that, how we are using it and what's new in this today. So I would like to invite my first speaker, Dr. Kanika Bharadwaj, who is a cataract and refractive fellow with Center for Sight. She's going to cover what are my options when I need protection, comfort, and clarity. So over to you, Dr. Kanika.
Yeah, this one. Okay. Okay, good morning everyone. I'm Dr. Kanika from Center for Sight Eye Hospital, and today we will be talking about specialty contact lenses. Now, as the name suggests, these are not the conventional contact lenses because they are mainly suitable for people who have corneal conditions or eye diseases which bar them from wearing the conventional ones. So coming to our topic, what are my options? Protection, comfort, and clarity. Let's get into the details. So specialty contact lenses are not just for special eyes. We can use them for various indications, starting with any ocular surface disease, such as keratitis, dystrophies, ulcers, keratoconus, keratoglobus, even lag ophthalmos, or even post-trauma, such as those people who have had corneal laceration and have now corneal scars, or even iris colobomas. People who are into sport activities who cannot wear the conventional ones, like those in field and track or water sports. Even those who are post-surgery, like after C3R or post-penetrating keratoplasty. There are others like those after refractive surgery, post-LASIK, and even post-LASIK ectasia. People who have very high astigmatism, and even those who are RGP failures. So there is a different terminology for different type of lenses. We will be focusing on the rigid corneal lenses of various diameters, starting from the rigid gas permeable lens that has been in practice from past many years. But what we are going to focus today is on the corneoscleral or the mini-scleral lenses, which have a diameter of about 14.5 millimeter. Now, what's special about these lenses? They do not rest on the cornea, and hence they rest on the white part of the sclera, therefore causing minimum irritation to the surface. This is how a scleral contact lens looks. On the left side, we can see an image, a fluorescein-filled reservoir that shows the extent of the scleral contact lens. We can see it is completely covering the cornea and it is resting on the sclera. On the right-hand side image, we can see how the scleral contact lens covers the corneal irregularity and how there is a fluorescein-filled reservoir in between. Now, coming to our topic, how does it afford protection? We know there are diseases, various ones at that, which affect the cornea, leading to unnatural shape of the cornea, or causing a lot of discomfort and dry eye, or even causing the cornea prone to trauma. So in such situations, these lenses provide protection. Because these lenses do not rest directly on the cornea, they do not irritate the surface, they are not uncomfortable, and they also not damage the ocular surface. As I mentioned before, the reservoir, it not just acts as a fluid in between, it improves the clarity, also provides hydration. So this is an example of a 7-year-old child with Stevens-Johnson syndrome. The child, we can see in the left side images, is not even able to open the eyes, and his vision unaided was 360 in both the eyes. Whereas after scleral contact lens application, the child is opening the eyes, and also his vision is improving to 618 and 612. So here it provides protection to the ocular surface. Age is no bar to these lenses. This is another example of a 65-year-old female with Stevens-Johnson. Both the 7-year-old child and 65-year-old female have benefited with scleral contact lenses, which is very evident from the clinical pictures. Now, how do these lenses provide comfort? Uh, we know in today's lifestyle, everybody is prone to using screen devices and they have symptoms of dry eyes. So it also provides comfort because they have a reservoir which is about 250 microns to 700 microns thick, and this reservoir keeps the cornea hydrated. Also, it avoids dry eye symptoms. The fluid that is filled inside is a preservative-free saline, which is suitable for people with Sjogren's or Stevens-Johnson's or other ocular surface dry eye diseases. So it fits even most difficult to fit corneas, and it doesn't irritate the cornea. On the right side, there's the video. So this guy had Bell's palsy and exposure keratopathy because of that, because his lid was not covering the cornea. So this guy not only got improved vision with the scleral lenses, his vision improved to 6.6, but also it protected him and provided him comfort from the exposure keratopathy. There's another example. This was a 27-year-old male with keratoconus in his right eye. The patient was using soft contact lenses from before, 2 years prior to consulting us. The patient had started developing severe discomfort, gritty sensation, and dry eye. He came to us to ask for a solution. We shifted the patient to scleral contact lens, and his BCVA improved from 6.9 parts with the conventional lenses to 6.6 with scleral contact lenses. Also, he had improved comfort because his dry eye symptoms were relieved. So we can also give these lenses not just for the corneal irregularities, but to give comfort to the patient. Now, how do they improve clarity? This is evident from my previous slides already that the vision improves. Let us see another case. This is a 30-year-old female, known case of advanced keratoconus. She even had Vogt stria. Her pentacam showed keratoconus grade 4. Her keratometry readings were in the range of 53 and 55 in the right eye, whereas 57 and 60 in the left eye. Patient with spectacles was only reading up to 624 parts in right eye and 624 parts in left eye. The patient, when given scleral contact lenses, improved to 6.9 in the right eye and 6.12 in the left eye. So as is evident from the patient, she was very happy because her vision clarity improved drastically. We can see on the left side how thin the cone was and how the reservoir protects the cone. Also, the lens provides clarity. So to conclude, I would like to say that always do not open new doors. We have to be in touch with the newer technology that is available and to be able to help our patients coming to our clinic apart just from visual rehabilitation. If we never try, we never will know. I would like to extend a special thanks to Mr. Gagan Sahani for all his effort and providing us with the lenses that we use in our clinic. And Mr. Dilip Singh Sidhosnia, who's our senior optometrist and contact lens expert at Center for Sight. We don't have any financial disclosures. Thank you.
Can we have question at the end of the instruction course? So, yeah. I would like to invite Dr. Krishna Teja. He will cover one size does not fit all, specialty contact lens fitting and customization. Dr. Krishna, over to you.
Good morning, everyone. Good morning, everyone. Today we'll be discussing about specialty contact lenses fitting and customization. Myself, Dr. Krishna Teja. And there is a case scenario. This is a case scenario where a 61-year-old male patient, both eyes post-RK, came with a chief complaints of blurring of vision, and we checked the spectacle prescription, and his BCVA with the spectacle prescription was 618 in both the eyes. And in that person, we decided to go ahead with the scleral contact lens trial, and we gave him the scleral contact lens, and the patient improved to 6/9 in both the eyes. This is a diagnostic lenses trial fit frame, and coming to the scleral lenses, 4 parameters are mainly important. They are the sagittal depth, geometry, landing zone, and the power of the scleral lenses. This is a paper showing that approximately 60 cases were required before obtaining a significant reduction in the trial lenses and reorders of the scleral lenses. And coming to the scleral lenses can be divided basically into 3 zones. They are the central zone, the limbal zone, and the landing zone. Coming to the central zone, it is the main fluid reservoir. It has the main fluid reserve. And the most important of the central zone is the sagittal depth. And this sagittal depth can be assessed with the diagnostic lenses. To start with the sagittal depth, mainly the primary important ones are the topography and the formula. Topography can be normally taken, and there are formulas, and these formulas basically given by the lens fitting company as a fitting guide. So these formulas are mainly based on the Simke values, and the values obtained by this formula are not an exact fit, but it gives you a start. And this is a diagnostic lens fitting trial frame. And in this, the increase of sagittal depth from the left to right of the scleral lenses will be there. And if you are not sure where to start from the mid-range sagittal depth and customize the fit. If you are dealing with a keratoconus patient, go with a steeper lens, and if you are dealing with post-PK or any refractive surgery patients, go with a flatter lens. And coming to sagittal depth, diameter versus base curve, if the diameter is the same and if this base curve has been becoming steeper, then there is higher sagittal value. And with the same base curve, if you want to increase the sagittal value, you can go ahead with a larger diameter. And coming to the application of the diagnostic lens, a diagnostic lens is taken on a plunger and it is filled with a non-preserved saline, and the saline is stained with a fluorescent strip, and then it is applied onto the eye. Then we go ahead with the assessment, fitting, and everything. So coming to the central zone, there should be a fluid reservoir of about 100 microns to 200 microns, and the fluid reserve is usually assessed with the diffuse illumination or a slit beam on a slit lamp. And this is a picture showing where there is a central low depth here and the peripheries are fine. But this is the picture where which is showing that the fit is good. And the vault of the diagnostic lenses assessed by comparing the thickness of the scleral lens with the thickness of the reservoir. The slit beam is usually at 45 degrees angle. For example, if you take a lens of 400 microns, the vault should be 1:1 ratio or about at least 80%. The settling of the lens also has to be kept on mind. This is a scleral lens fitting guide given by first Ferris State University. After this guide, the fitting of the scleral contact lenses has been drastically improved. And the reservoir can also be assessed with the help of an OCT, the anterior segment OCT. This is the most accurate method, and prefer to do OCT on the best fit lens rather than each and every trial lens. Coming to the scleral lens settling, there is a short-term and long-term scleral lens settling. And in the scleral lens settling, there is a loss of vault and expect to lose up around 200 microns. And 50% of the settling occurs in the first 30 minutes of the application of the scleral lens. And most studies show that around 180 microns of clearance is there. And coming to the customization of the central zone, I am just going to play a video. Audio, please. Audio.
Where is audio?
Thank you.
The sag value determines the general vaulting characteristics from center to limbus. The range is from 3,800 microns to 6,600 microns in 50 micron increments.
Coming to the limbal zone, The limbal vault size should be around 25 to 75 microns, and the chronic wear of a low limbal vault, it gives us a limbal keratitis or neovascularization at the limbus, and it is a good thing to differentiate between a decentered lens and a tight fit lens. In the left, it is showing a tight fit lens, and here this is showing a decentered lens, and one quadrant of decentered lens is fine and acceptable. And coming to the diameter selection of the scleral lens, there is no clear consensus of the selection of the diameter, but greater than 16 mm diameter is usually suggested. With the increase in the diameter, there is more limbal clearance and increase in the sagittal depth. And the limbal clearance, usually the fluorescein stained central zone, and the limbal zone is usually seen with the help of cobalt blue light or white light or a slit. And the another method to assess the limbal clearance zone is the limbal OCT, anterior segment OCT. And there is customization at the limbal zone also, and I'll be playing a video on that.
The mid-peripheral and limbal values are sub-adjustments you can make within a specific SAG value to achieve the desired clearance in those specific areas. Adjustment to the M and L values do not affect the central vaulting characteristics of the lens. They can be made independent of each other and in opposite direction when needed. The range of the M and L values is plus or minus 200 microns in 25 micron increments.
Coming to the geometry of the scleral lenses, some companies manufacture in such a way that one size fits all the geometries of eyes, and in some companies they produce different lenses for prolate and oblate eyes. And there is a small customization in the oblate eyes also, and I'm going to play a small video on that.
Use oblate geometries also give you the ability to control any excessive central clearance. Oblate geometries are derived from the regular prolate trial lenses. From your observations of the trial lens in situ, simply specify one of 4 levels of central clearance reduction values. The central clearance reduction is limited to an area of 7.5 millimeters in the center of the lens and does not affect the other vaulting characteristics of the lens.
Coming to the landing zone, depending upon the landing zone, there are 4 kinds of lenses: spherical lenses, toric, quadrant specific, and free-form lenses. The landing zone should rest evenly on the sclera. There should be no compression, impingement, or edge lift of the bulbar conjunctiva. Allow the lens to settle for 30 minutes after fitting there and reassess on the slit lamp diffuse light. And this is a picture showing here, this is a scleral lens, spherical scleral lens. Due to the toricity of the conjunctiva, there is here compression in these areas. So in such conditions, we would be able to go ahead with the toric lenses. Coming to lenses with toric landing zones, the companies provide toric landing zone diagnostic lenses also. The orientation is orientation useful for front surface toric and localized walls also. And coming to the asymmetric lenses, asymmetric conditions of the sclera, the quadrant specific designs or free-form lenses for asymmetric lift or localized impingement can be tried. There's a small video on toric and quadrant specific lenses. I'm going to play that.
When needed, due to conjunctival asymmetry, toric and quadrant-specific edges can be specified.
Once a best fit lens has been decided, we can go ahead with the contact lens over refraction. Spear cylinder over refraction can be done, and front toric surface lenses can also be customized, and the scleral contact lenses can also be customized with the wavefront customization. And coming to the future of scleral lenses, the profilometry is the future of the scleral lenses. Corneoscleral topography, shim-plug topography of the sclera, and the impression techniques of the sclera gives us a good fit lenses. To conclude, one contact lens doesn't fit all the eyes, so different customization options are available everywhere, and we can take the help of the customization from the companies, and we can give the best vision to the patients. I thank everyone who has helped me during this process. Thank you.
Thank you, Dr. Krishna, for those basics of the fitting as well as the illustrative videos. That was really helpful in understanding this complex topic. I would like to invite Dr. Tulika Chauhan next, who is the chief instructor for our course today, and she's going to be talking about the future of these specialty contact lenses with us. Dr. Tulika, ma'am, please.
Thank you, Dr. Kangsha. A very pleasant morning to all of you. I am Dr. Tulika. I will be covering what's new. What Dr. Krishna has spoken about is something which we do in our day-to-day practice. So do we need something new? Because according to him or other speakers, what we are doing is perfect. So are we perfect right now? And if we are perfect, then what is the need of new? So when we question this, that we need something new, that means the existing technologies might not be perfect. So, as a ophthalmologist, when I'm taking care of diseased ocular surface, my aim is to align curve of the contact lens with the diseased ocular surface. But we all know that contact lens bound to move on the surface. It works very well on the surface which are healthy, but will it work on the surface which is unhealthy? So, what method we are using is called trial and error in India, which is very prominent, very dominant in India. But what will happen? Multiple trial and errors, unhappy patient, disappointed doctors, right? So that is why we need something new. So we need a custom fit. So I just wanted to tell you that why I need a custom fit for my patients. Because ocular surface elevations, when you see ocular surface disease patient, you won't find a normal ocular surface. We will find ocular surface elevation in form of pinguicula, pterygium, irregular corneal grafts, Salzman nodal degeneration, and other nodal degeneration as well. Post-surgical patients like filtering blebs, tube shunts. So what it does, if we use a trial and error method, then what will happen? We do a lot of lens modifications, like we do a lot of notchings and peripheral lens elevations, quadrant-specific design or truncations. That means your patient is coming again and again to you, right? So what custom fit avoids? It avoids reordering of lenses, it avoids remake of lenses, and it avoids non-revenue follow-ups, because your time is precious and the patient time is precious as well. So that's why we need a custom fit for each eye. So we'll discuss what is new right now in contact lenses. I'll be covering predominantly scleral contact lens, which we practice in our day-to-day practice. So there are two technologies. Very important is empirical techniques, which cover corneoscleral profilometry. The instrument used for this are scleral topography, corneoscleral topography, corneal tomography, ASOCT. And the future is wavefront custom specialty contact lenses. So this technology we might not have everywhere freely available in India, but in Europe they are using it a lot for customizing the specialty contact lens. The second technology which is very popular, which is about to come to India very soon, is impression-based technology. It is custom mold. Predominant market is eye-print prosthetics. We'll cover the impression-based technology. What it does, it takes a globe impression. So the process involved, we take a globe impression with a molding material. It make a digital model of the eye using the 3D scanner, and the scleral lens is designed with a proprietary software based on ocular elevation measured by impression mold. This creates a highly customized and incredibly specific, comfortable, and stable scleral lens for the patient. So eye-print prosthetic is FDA approved, and they make three kinds of lenses. The first two lenses which I'm going to discuss here, they are based on the impression technology. So eye-print Pro is the lens which is the exact replica of your ocular surface, and it works wonderfully well with the very diseased ocular surface. Whether you have a filtering bleb, you have any nodal degeneration, shunt, and even simplifron. The second lens, which is iFit Pro lens, which creates exact replica, but it is recommended for the less diseased ocular surface like post-traumatic ocular surfaces, irregular corneal transplant, and small Salzman nodular degenerations. Third lens, which is very popular, which I'm covering here because it works with empirical technology. It is not it doesn't take impression globe, but it works with the scleral topography. But because it is marketed by iPrint Prosthetic, I'm mentioning this here. So it also make a ocular surface replica, but it works with the scleral topographers. So what iPrint does, they use oxygen permeable material, high decay material, which vaults the cornea, and the lens land on the sclera, so it's a scleral lenses, and they use the elevation-specific technology using a molding material. And this coating is tangible hydra so that there is no deposition on the lenses. And they take the impression. This impression will go to the lab where with a 3D scanner, they make a digital print of the eye and they design the perfect lens for the patient. So how we do it in the clinic? So this is not my personal video. This video is taken from the iPrint Pro. So this is a molding material which is inert in the eye. We take the impression and we get this 3D scanner digital print of the eye, and this print is sent to the lab. And there are the software where the documents are added and the patient's measurements are added, and they end up making the lens. So how it helps? It decreases the remakes because you have exact replica of your ocular surface, so you're going to make a perfect lens for the patient. So this is how the mold looks like after you take it from the eye, and this mold will go to the lab. So empirical techniques. Empirical techniques are very important. Why? Because it doesn't touch your eye. It is not going to put any material in your eye so patients are very comfortable. It's not an invasive procedure. So what we do in empirical techniques, we do ocular surface profilometry. If we have a profile of the whole ocular surface, we are able to make a perfect lens for the patient. So why it is important to have ocular surface profilometry? As far as scleral surface is concerned, we are not sure whether our sclera is spherical, toric, or asymmetrical. And as we know from the studies that scleral asymmetry topography is independent on your corneal counterpart. Your cornea will not reflect your scleral topography. And we all know why we need corneal surface. We need to know the irregularities on the cornea because that's what we are going to overcome through these lenses. So it can be in the form of astigmatism, it can be in the form of elevations, it can be in the form of distortions. So the scleral topography is something which I want to cover here because these scleral topographies are used to customize the lenses these days. So it replaces the trial and error method which we used in our day-to-day practice. It makes the fitting faster, it saves the chair time, reorders, remakes, follow-ups, and scleral surface mapping will lead to the custom design lens unique to that particular eye. So mapping technique use reflection-based system with projected pattern sequence to map the cornea and the scleral surface. And this projection comes from using fluorescein to the ocular surface. With lid retraction and the eye excursion, profilometry techniques are capable of imaging beyond 20 millimeter scleral cord. So immediately detect the need of toric landing zone and how much toricity is needed to optimize it. So current topographers which are available in the market, unfortunately not in India, but yeah, they are available. So one is S-MAP 3D. It is from Visionary Optic. It takes 1 million data points on the ocular surface. It covers almost 22 millimeter of sclera with a precision of 10 micron. It uses sodium fluorescein for the image acquisition, for the projection, and it takes image in 3 gazes, straight, up gaze, and down gaze. The only drawback of this instrument is that it stitches all the 3 images to make an ocular surface profile. So then, to overcome this, this is a video from 3D mapping. So that's how it profiled the sclera. It takes almost 22 millimeter of sclera and profile it for us. And this data will go to the lab. These measurements will go to the lab for the customization of the lenses. So because it stitches the images, there are chances of error. So this eye surface profiler is from Eagle Eye. This is again a scleral topographer available. It takes 3,000 to 500,000 data points. It covers almost 20 millimeter diameter of sclera. It also uses impression technology for image acquisition. But the best point is it takes single image in primary gaze. And the device will automatically generate the best fit lens design. In this instrument, it will suggest that what would be the lens algorithm and which lab works on these algorithms, and you can directly send the data through this machine. I'll show you the video here. So this is the image acquisition by Fourier transformation. It just read 500,000 data points. We just put a fluorescein, and this scleral profilometry comes. And on the basis of that, it gives you first lens algorithm and the suggestion that which lab will make this algorithm for you. And through the direct connect, though we don't have it in India, but this software can send this data to the company, and the lens can be made from the lab. Another thing, if you don't have scleral topographer, if you don't have a very great scleral lens practice, so scleral topographer will be very expensive. So in India, what works for us is corneal tomography. So the Pantacam. So Pantacam, not every model, but some model of Pantacam have corneoscleral profile module. So it maps the sclera as well as cornea. It acquires 250 points, 100,000 data points, 250 images of 100,000 data points. But it again take images in 5 gauges, and they stitch those images and make the ocular surface. Anterior segment OCT, as Dr. Krishna also covered, is very helpful to see the clearance in micron because it does not cover that much sclera. So Pantacam works better for us in our day-to-day practice rather than anterior segment OCT. But if it is available, it helps to profile the surface. So the limitation is it measures sclera in the static surface of the its static surface. But the eureka points are there. Why scleral topographer is so popular with the scleral lens practitioner? Because it creates the free-form lenses. Free-form lenses, that means you can optimize and customize lens according to the ocular surface. Asymmetric lenses with multiple meridian of toricity or highly irregular surface. Vault pathological elevation without sacrificing other parameters such as diameter or base curve. And the freedom from complicated lens modification as notching or truncation. When we do assumption, truncation, or notching, we might end up making not the great lens for the patient. It is not custom fit for that eye. So that means scleral topographer help us to avoid those things. We can combine these technologies. For example, if we have the irregular pupil or abnormal visual axis, what we can do? We can use a decentered optics with scleral profilometry, and we can design a lens in which we have a decentered optics and patient can have a better vision. Aberrometry with ocular surface profilometer is a great combination. Optivis is the company which is providing this combination these days. And ocular surface condition lead to increased higher order aberration. Free-form lenses can neutralize the higher order aberrations. So wavefront guided custom fit is important because wavefront guided custom lens technology is designed to specifically target the unique aberration of individual eye, particularly the elevated levels of residual aberration experienced by highly aberrated eye wearing conventional contact lens. So what it does, this is a machine marketed by OVETS. They check the wavefront of the eye, they check the aberration of the eye, and these aberrations was charted, and they were embedded in the lens, what they design here. So these lenses will overcome higher order aberration in the patients. So the pinnacle point would be in scleral lens when we can customize best optical and visual performance for every eye. So this is from my side. Thank you very much.
Thank you, Dr. Tulika. Now I'd like to introduce Dr. Akansha, who will be speaking about contact lenses and keratoconus. Over to you.
Full screen, full screen.
So a very good morning to everyone. After that impressive peek into the future, I'm going to go back again to the very basics and a very common condition that all of us see in our clinics. I have no financial interest in the following presentation. So we all know that keratoconus is the most common ocular ectatic disorder, and the basic pathology is there is an area of thinning and protrusion, which is giving rise to irregular astigmatism and myopia, and the patient is having a very poor quality of vision. It is a progressive and a non-inflammatory disease. Now, what happens to the patients of keratoconus is that the structural abnormalities in the corneal layers as well as the altered tear film layer leads to a lot of halos and image distortions. So when these patients complain that we have poor quality of vision, sometimes we tend to underestimate how poorly they are seeing. And this is a simulation of how their vision can be, and it's obviously a major impact on the quality of life. So the management of keratoconus in itself is a very big topic for this discussion, but sticking to the topic of discussion today, in the mild and early cases of keratoconus, glasses would be adequate for visual rehabilitation, but the patients of moderate to severe cases may do much better if we give them the option of using a contact lens. So now there are a variety of contact lenses that can be used in these patients, starting from the soft toric contact lenses, the more commonly used gas-permeable lenses, as well as special lenses such as hybrid lenses, piggyback lenses, mini-scleral and scleral lenses. The soft toric contact lenses can only be given to your patients of keratoconus who are early on. They don't have much steepening of the cornea, and the primary refractive error is a low astigmatism with high myopia, and if they are very intolerant to gas-permeable lenses. But for most of the other keratoconus patients, that is ranging from the moderate to severe type, the gas-permeable rigid lens gives them a very stable optic surface and reduces their aberrations. And plus, they give the advantage that there is no limbal touch. It's purely a corneal lens. Therefore, the patient may be more suitable for RGP lenses. The RGP lenses can be spherical, aspherical, or it can be a combination of both. In case the patient is not tolerating an RGP lens, a piggyback system, as can be seen in the picture, shows a soft contact lens as a base over which a rigid gas-permeable lens is placed, therefore improving the patient's comfort. A hybrid contact lens, as discussed, which has a soft peripheral portion and a high gas-permeable center. There are specialized contact lenses as well, but the advantage comes when you offer scleral lenses to the patient, which vault over the cornea. And nowadays, with more specialization, there are customized computer-assisted contact lenses as well, which are called the PROS lenses. Whenever we are fitting a patient of keratoconus with a contact lens, we are creating a homogeneous optic, reducing the aberrations and therefore improving the visual quality. Because there is minimum contact with the surface, there is no pressure, there are less chances of the ectasia progressing or any evidence of scarring that may tend to increase if there's a lot of touch with the cornea. And the minimum contact with limbal area will also mean that there's no conjunctival injection or intolerance to the lens. So based on the different presence of cones in the patient, the contact lens fitting has to be customized for that patient depending on the position of the cone, and the parameters of the lens are to be decided based on this. As we said, the scleral lenses, they are vaulting over the cornea, there's no contact, and therefore it is a much safer option and much comfortable to the patient, those who are not tolerating RGP lenses. And because the lens seals the bulbar conjunctiva, there is minimal tear exchange occurring under the lens, and therefore the patient may need to replace the solution that is inside the lens every 6 to 8 hours. So this is how a scleral, well-fitted scleral lens looks over the cornea with a good vault as well as minimal conjunctival blanching or any irritation at the limbal area. Traditionally, apical clearance and apical bearing were the two types of lens fittings, where you can see in the apical clearance that there is a pool of fluorescein that can be seen centrally. In the apical bearing technique, there is a apical touch, but the advantage that this lens gives is the patient gets better vision. But when using it over a long time, it can lead to scarring over that area, and therefore we have now shifted to a 3-point touch technique of contact lens fitting, where there's a minimal apical touch, a mid-peripheral bearing, and then a peripheral touch again. The most important of the lens properties that you need to be sure of before you dispense a contact lens is the lens diameter, the base curve radius, and the power. There are various trial sets available from different companies along with their recommendations. You can try with the keratometry readings, fit on a lens, and then based on the dynamic and the static fit of the lens, either increase or decrease your settings so that the patient becomes more comfortable. Dr. Krishna had discussed about the sagittal depth. What is important to remember here that a patient having the same keratometry, that is the two pictures that you can see here, even a patient with the same keratometry reading can have very different sagittal depths. And how is it important? Because if the patient's contact lens fitting has very high sagittal depth, there will be bubbles under the lens and the lens will ride low. And whereas if the sagittal depth is not enough, the lens will keep decentering. So you can modify the base curve of the contact lens, the peripheral curve, and the lens diameter to give them a complete fit along with a good sagittal depth. If your lens is riding high or riding low when you look for the contact lens fitting, you need to change the diameter, the base curve, or the edge lift, and make sure that the patient is having a centralized contact lens with minimal movement. There can be a mid-peripheral contact point along the horizontal meridian, but the lens should have unobstructed movement along the vertical meridian with each blink. A spherical over-refraction is then done once you are happy with the fitting of the lens, and whatever is the spherical over-refraction, you can make changes in the power of the lens accordingly. So this is how a well-fitting vaulted scleral lens is looking on the eye. Even if there is an area of central scarring, there's no touch in that area, so you're not at risk that if the patient is on chronic use of these lenses, the scarring may increase. Now, after all this information, how it is important to take this to clinic, I'll just be giving few basic simple examples of how it can benefit the patients of keratoconus. So this was a male patient of keratoconus. Left eye had advanced keratoconus. This was the right eye pentacam. And this is the left eye. So the vision in the left eye was very poor, 20/100 as you can see, and not improving with glasses. But when an RGP contact lens was given to this patient, we could improve the vision up to 20/20 partial. The patient was very happy with the contact lens. This was the 3-point touch technique of the contact lens fitting. Sometimes you may have a patient who's not a classic case as in just keratoconus. This patient had, 36-year-old patient, had advanced keratoconus, and the left eye had developed eye drops earlier, which are now scarred. Had very poor vision, and the patient had actually never had good vision in the left eye ever. And when the mini-scleral contact lens trial was done in the left eye, the vision improved to 6/12. So the patient was really happy because he had never even expected that he would have that good vision with his left eye ever. So after the contact lens fitting, and always for scleral lens, we need to remember that a 4 to 6 hours extended contact lens trial also needs to be done to make sure that even over a period of time, the patient is comfortable with the lens. If it's a patient even of advanced keratoconus, where as you can see, because of the thin pachy, cross-linking could not be done in the right eye, but it was done in the left eye. Even in the advanced keratoconus eye, with a mini-scleral contact lens of the following parameters, the vision could improve up to 6/9 in that eye, which was so advanced. So it's a very good option for patients where you may not even be able to do a cross-linking, but having explained that if there is progression, the fitting of the contact lens may change. So a good fitted contact lens with giving the patient good visual acuity is going to make the patient happy as well as the doctor happy. So it is to be remembered that all patients whom we are not able to improve, give them good quality of vision with glasses in keratoconus, they should be offered specialty contact lenses. In association with a contact lens specialist, the correct contact lens should be dispensed, and they are absolutely safe if they are of the correct fitting and the patient knows how to take care of the lens. And with the quality of vision that the patient gets, the patient would come back to you regularly and get more people to take the contact lens. So a happy patient will lead to a happy doctor. Thank you.
Thank you, Dr. Akanksha. You've wonderfully covered almost everything in KC with contact lenses. May I invite Dr. Yoganki Kush, which is going to cover the role of contact lenses, specialty contact lens in the dry eye.
Good morning, everyone. I will be covering specialty contact lenses in dry eyes. So in this presentation, we'll try to find out Which conditions of dry eyes need specialty contact lenses? What kind of specialty contact lenses can be used in dry eyes? What is the mechanism? How do they work? What are the advantages they offer? And are there any long-term or short-term changes on the ocular surface? What are the limitations in these cases? So coming on to the conditions of dry eyes, any condition which is compromising the ocular surface, causing drying and desiccation, and not controlled by the medical management can be given good rehabilitation via the contact lenses. The condition like severe dry eyes, which are refractive to the conventional treatment, Sjogren syndrome, keratoconjunctivitis sicca, even in limbal stem cell deficiency cases, contact lenses are found to give good results. Neurotrophic keratopathy, cicatrizing conjunctivitis, and also in cases of post-refractive surgery, dry eyes, and chronic graft versus host disease. Now, which type of contact lenses to be used in these conditions? Like it has been all previously discussed in other slides, the scleral contact lenses is the answer to the question. This is a small video showing the how clinically we use scleral contact lenses. This has been previously discussed by my colleagues. So this is the plunger. Plunger needs to be filled with a fluid attached to the lens, and then a fluorescent strip to look for the reservoir. Coming on to the mechanism of action in these cases, so there is a fluid cushion effect. Fluid cushion effect over the cornea by vaulting all through it. So it provides hydration to the ocular surface by maintaining the reservoir, by causing decreased inflammation. So there is a decreased need of using lubricating eye drops, thus providing the dried ocular surface an opportunity to heal and breaking the vicious cycle of the inflammatory mediators. Also, there is a mechanical protection of the cornea as the lens provides a surface so that the keratinized lids cannot rub over the cornea. So how does these lenses help in these conditions? They provide restoration and support to the ocular surface, help in visual rehabilitation and correction of the corneal irregularity. They also provide pain attenuation, and in cases of Bell's palsy, leg ophthalmos, and lid trauma, they prevent the desiccation due to exposure because they are covering the irregular surface. Also, they protect the cornea from microtrauma caused by blinking. Now, are there any long-term or short-term changes to the ocular surface by the use of these lenses? So the short-term effects on dry eye biomarker is there is no change in the Schirmer or the T-BERT, but there is decrease in the tear osmolarity and the OSDI symptom score, that is the ocular surface disease index. There is significant rise in the matrix metalloproteinase 9 concentration in the tear film. The long-term effect, the study says that there is the use of proscleral lenses. There was improved OSDI score from 56.54 to 24.98%, and the corneal staining pattern were decreased. So this is a case from our clinic where this, in this first image, you can see that this is a poor ocular surface with central corneal scarring and this corneal thinning, and the patient's vision was 660 initially, and with the scleral contact lens, we were able to give him a vision of 612 parts. So there is another case with a poor ocular surface, and in this case, we could give the patient a visual rehabilitation up to 6/9, whereas the unaided vision was counting finger 3 meters. So this is a short video. Few slides have been discussed, but this is covering the ocular surface disorders where scleral lenses can be used and how they provide visual rehabilitation in these cases. So there was a 7-year-old boy of Stevens-Johnson syndrome whose unaided visual acuity was 3/60. With scleral contact lens, we could give him the visual acuity of 618 to 612 in right and left eye respectively. Another case where the unaided visual acuity was 6/60 could be improved with the scleral lenses up to 6/6 both eyes. And another case of Stevens-Johnson where the visual acuity improved to 6/9. Also in cases of chemical injury, the lenses have seen to be providing good vision. So coming on to what are the limitations we face in these cases. First is the cost effectiveness of these lenses. Although the first case report dates back to 2000 by Rosenthal et al., but this technology is relatively new and advancing, as has been discussed by Dr. Tulika. More training to use these lenses in terms of the person providing the care, as well as the patient needs to be very careful. Also, there can be difficulty to fit in ocular surface problems where there are shortened fornices and multiple conjunctival problems. One of the major limiting factors is eye care providers are not aware about the therapeutic benefits of scleral contact lens in these conditions. So I would like to conclude that scleral lenses can be successfully used in the management of severe dry eyes and ocular surface disease. In addition to providing visual rehabilitation, they protect the surface by maintaining a fluid reservoir. Thank you.
Thank you very much, Dr. Yoganki. So now we know that in very severe dry eye, we have options until we say that patient has no potential of vision. We should try these options and patient do wonderfully well. So thank you very much. I would like to invite Dr. Pratiksha Sharma to cover specialty contact lens in irregular cornea. Thank you.
Thank you, ma'am, for inviting me. As my friend Dr. Akansha has already covered part of keratoconus, I am going to cover the rest of the irregular corneas. So I am going to talk about the tip of iceberg, that is contact lens in irregular corneas. So no financial interest. So why we want to cover this topic? Because not every contact lens fits every eye. So we can see in this picture there are various type of irregular corneas. So what are these specialty contact lenses? Basically these are specialized contact lenses which are designed for exceptional cases. So what are the various exceptional cases which we see in our OPDs? So one is keratoconus, which we have already discussed, and besides that we also have pellucid marginal degeneration, we have scarred corneas, then we have post-LASIK, RK, post-PRK, post-PK. We also have post-intact dry eyes, then even some high astigmatism prescriptions. So what are the various options available for these type of eyes? So we have conventional corneal lenses of RGP, then we have piggyback system, we have hybrid lens system, custom soft toric lenses, Rose K family of lenses, also we have scleral lenses. So what are the basically requirements or the indications of corneal RGP lenses? So they are made up of PMMA and they are indicated in cases of early to moderate keratoconus, also in corneal scars, high astigmatism, as they are very easy to fit. But still they are associated with various disadvantages, which include high contact intolerance, then there are frequent contact lens displacements. The visual acuity is unsatisfactory despite being good contact lens fit, and not all patients can be fitted with RGP. So what if the patient cannot tolerate RGP? So the other options are like piggyback lenses, hybrid lenses, and custom soft toric lenses. So what are piggyback lenses? As we can see in the picture, there is a rigid lens which is fitted over a hydrogel lens. So as a result of this, it increases the comfort, resulting in adequate wearing time with good vision. So again, the advantages include that it reduces the mechanical trauma because of the hard lens material, which can happen in RGP. that it improves the patient's tolerance, it heals the epithelial erosions, and the combination with the comfort of silicon hydrogen lens, but with the optical superiority of the rigid lens. But it is again associated with some potential problems, which includes that we have to pay for 2 lenses. Handling and care of 2 different type of lenses is completely different. Then difficulty in obtaining centration of rigid lenses over the soft lenses, and there are associations of hypoxia and neovascularizations. So then we came for a new solution, which is called the hybrid soft lens. It includes RGB plus soft lens. So as again you can see in the picture, there is a rigid gas permeable lens at the center and soft exterior. So contact lens with RGB central portion and a soft lens material skirt. But again it is associated with some complications like flexure of the center lens, which is the hard lens, leading to astigmatism and decreased visual results. There are always association of difficulties with insertion and removal of such type of lenses, and the cases I've seen that there is tearing at the junction of GP lens and hydrogel skirt. So then we came for custom toric soft contact lens. So these have 3 zones. They are silicone material. They are tri-curve posterior design with increased corneal thickness, and we have various lenses available in this category like Carasoft IC and Puricon lens. As you can see in the picture, there are 3 curves at the posterior design. So indication of such lenses include from first keratoconus, then we have high astigmatism and post-LASIK ectasia. Again, there are disadvantages like it is not suitable for advanced cases, and there is a compromised vision clarity compared to RGP lenses. Then we came to rose K lens. So rose K lens it has a complex geometry which can be customized to suit each eye, and it can correct all type of myopia, astigmatism which is associated with keratoconus. So they are very easy to insert, remove and clean. They provide excellent health to the eye because they allow cornea to breathe oxygen directly through the lens. So we have various type of lenses. In this includes rose K2, which is available for oval keratoconus, nipple keratoconus and early pellucid marginal degeneration. So we also have K2NC. All these differ on the basis of the edge lift. So we have rose K2NC for moderate to steep nipple cones. We have rose K2IC for pellucid marginal degenerations, keratoglobus, LASIK-induced ectasia, post-graft, and we also have a specialized range of rose K2 post-graft for patients who have undergone penetrating keratoplasty. Then we have scleral lens, which we have already seen. So these scleral lenses, why we prefer them? Because they give lot of comfort, which is equal to or better than the soft lenses. Then the vision associated with scleral lenses is equivalent to RGP optics, and it can be used for eye health in cases like dry eye, epidefects and ocular surface diseases, and they are usually not lost. So again, the indications include advanced keratoconus, where contact lenses do not work, and poor compliant patient or patient refuse surgery. Then they completely neutralize the corneal irregularities. As you can see, and we have already seen in the previous slide with Dr. Krishna, that when we insert a scleral lens, there are 3 zones formed. So how do these lenses work? So basically there is no corneal bearing, corneal clearance is present, limbal clearance is present, there is a tear reservoir between the lens and the eye, and the final lens depends on the corneal elevation and sagittal depth of the eye at the point of bearing of the sclera, which we have already seen. So again, it is associated with various advantages like better comfort, less mechanical trauma to the cornea and better vision. But again, why then the scleral lens is not popular? Because it is very expensive, it is a large lens diameter, it needs practice to insert and remove the lens, it needs more maintenance, there is lack of expertise to fit, and there are various complications when patients wear it for overnight. Thank you.
Thank you, Dr. Pratiksha. Thank you for the wonderful presentation. So we have discussed what contact lens do best. Now something can go wrong as well. So Dr. Raghav is going to cover that what can go wrong with scleral lens, what are the complications with the scleral lenses.
everyone. So now that we've had a good discussion about the uses of these specialty lenses, now we need to know, and as is the rule of nature, that there can be no good without any harm. So I'll be discussing about complications in these special lenses that we use. Okay, so now these are some complications of our regular soft contact lenses which we wear for regular myopia or hyperopia or astigmatism. These can also occur in these specialty lenses. These include, of course, hypoxia. We know there are patients who sleep with contact lenses overnight. That is something which is not a very good habit, but yes, we have to ask our patients not to wear these lenses overnight and not to abuse the lenses, because this is something that the patient has to fall back upon as an option where surgery cannot be done. So, of course, this should not be abused. Patients can be allergic and can have toxic effects of the material to the contact lenses. By mechanical effects, yes, there can be abrasions. The most common cause of intolerance to lenses is because of the touching of the lid surface and the lens. That is why patients are uncomfortable. So we have to see for proper fitting. Osmotic effects, of course, because of the change in the hydration of the epithelium and the anterior stroma, there can be osmotic effects. And infections, of course, can occur because the natural habitat of the contacts of the cornea is being changed. A contact lens is placed over the cornea. There are continuous hydration changes, osmotic changes that can predispose the cornea to infections. And of course, immunologically, the contact lens can be rejected. So now I'll come on to some complications of these specialty lenses. So now, in a nutshell, we can divide them as non-adverse and adverse. In non-adverse, we have complications like excessive corneal clearance. So let's get two terms right. What is clearance and what is bearing? Clearance means a gap and bearing means touch. So we can have excessive central clearance, corneal bearing, corneal staining, air bubbles in the center or the periphery, midday fogging, limbal bearing, conjunctival impingement, conjunctival staining, and lens adhesions. These complications are non-major and can be tackled with pretty much any amount of ease. So now this is excessive central clearance. As you can see, this image in the center shows a decent corneal clearance. You can see the contact lens, the surface of the cornea, and the clearance in between. In case we have an excessive clearance, that is the sagittal height greatly exceeds that of the height of the cornea, we can have a high central clearance, and the patient will experience reduced visual acuity, visual disturbances. There can be fish bowling, that is because of high, like Dr. Akansha also mentioned, if we do have a central clearance, then we can have fish bowling in the center. Patient will have disturbed visual acuity. There can be fogging and corneal edema. So we can reduce the sagittal height of the lens, and this can be easily resolved. Now, corneal bearing, like I said, bearing means touch. So yes, of course, when any foreign substance touches the cornea, there can be complication. If the lens bears on the cornea or we are giving an undersized contact lens, patient can have corneal bearing. Patient will have discomfort, corneal molding, epithelial erosions, microcystic edema, epithelial bullae, and lens adhesion. That is, the lens can get stuck to the cornea. So we can increase the lens sagittal height where staining is being shown, and that can circumvent this. Corneal staining, yes, because of corneal bearing, because of small vault, that is a small clearance. Air bubbles and hypoxia, we can have corneal staining. This could be from very small epithelial punctate opacities to coarse epithelial defects. So patient will have discomfort, foreign body sensation, contact lens intolerance, punctate staining, diffuse staining, sometimes even Corley staining, which can go on to keratitis. So the lens wall needs to be increased. Of course, air bubbles, very common. We can see central as well as peripheral. If we have a higher vault, we'll see them centrally. If we have a lower vault, we'll see them peripherally. Patient will have discomfort, will have reduced visual acuity, corneal Dellin formation, corneal desiccation, and ultimately, yes, ulcers can also develop. So we should reduce the lens sagittal height, increase the landing zone width, steepen the lens edge, and switch to a smaller size contact lens if possible. Midday fogging is nothing but mild edema in the cornea. Most common etiology is an atopic disease. If patient has allergies, if the patient has an underlying atopic disease, that needs to be managed. Excessive vaulting, tight fitting, mechanical stress of a flat landing zone can also can also cause midday fogging. This image shows fogging of the cornea. You can imagine what vision the patient will have. He will have discomfort, he will have intolerance, he will want to remove the contact lens, and of course that cycle starts all over again. So we can manage the atopic disease primarily, reduce the lens diameter, reduce the lens sagittal height. All this can circumvent a midday fogging. Limbal bearing, yes, if we give a small lens without adequate vaulting of the cornea at the limbus, we can have limbal bearing. Patient will have discomfort. Looking at the images, you can see this is a good limbal bearing. As shown by the AIOC also, you can see a decent size shape between the limbus and the contact lens. If there is bearing and this vault is not as much as it should be, patient will have discomfort. Limbal staining, limbal stem cell deficiency because of chronic use, limbal edema, and epithelial bullae keratitis. So again, the treatment is increasing the contact lens diameter. Conjunctival impingement, of course, because of mechanical effect of a harder contact lens, we can have vessels that are being obliterated or being impinged on by the contact lens. This could occur if there is a circumferential lens edge which is too steep, sectoral lens edge is too steep, and we have an irregular conjunctiva, especially in our elder patients. So the patient will have discomfort at lens removal and arcuate conjunctival staining and also conjunctival hypertrophy. How we can circumvent this is by flattening the lens edges if available or flattening the base curve of the contact lens. So these images show you a certain blanching of the conjunctiva where the contact lens hits the sclera and the conjunctiva. Here you can see impingement of these vessels. Now, conjunctival staining can also be there because of conjunctival impingement. Ultimately, once the patient takes their contact lens out and we stain the surface, we can see conjunctival staining. Patient will have discomfort and occasional dry eye. Lens adhesion occurs if the patient has pre-existing dry eye, oblate cornea, or low corneal clearance, or a steep landing zone. Patient will have discomfort, conjunctival imprints, ocular trauma, edema, inflammation, and ultimately infection. So patients should be given good lubricating drops, switch to a fenestrated lens so that patient can have, so these adhesions can break, and patients should be asked to take breaks during the day. Now there are certain adverse events that can be termed as complications that are not very easily handled. These include epithelial bullae, corneal edema, neovascularization, chemosis, and ultimately a giant papillary conjunctivitis, which is chronic in nature. So this shows epithelial bullae because of hypoxia. Of course, patient wearing the contact lens overnight can present to you with epithelial edema and ultimately will have stromal edema and midday fogging. So patient will have mild to moderate discomfort and conjunctival redness. This image shows a bulla under the lens, and also the AIOC showing the lens. This is the clearance, and then the epithelial bulla. Corneal edema, of course, this is of course an extrapolation of the epithelial edema. If the patient has hypoxia or the lens mechanical stress is being induced, patient will have halos, will have glares, bullae, and the entire cycle, ultimately leading to these bullas breaking, edema, and infection. Neovascularization, as also with soft contact lenses with chronic use, if there is mechanical stress in the limbal area, lens adhesion, and conjunctival prolapse, new blood vessels start forming. Chemosis, if we have reduced limbal clearance, patient will have discomfort, lens impingement, and lens adhesions. And ultimately, a GPC, mechanical friction with the lifted edge. This is the most common form of conjunctivitis we will see with our lens wearers. This is chronic in nature. Once this sets in, patients are no longer very comfortable with lenses. So unless treated properly, patient will never have good comfort. So patient will always be aware that he is wearing a lens. There is foreign body sensation, reduced wearing time, large papillary excrescences, of course, will probably require intertarsal injections also, and mucus formations. So in a nutshell, gas permeable and specialty contact lenses are continuously evolving to minimize complications and optimizing their fitting relationship. There is no gain without loss. Describing in detail all of these issues and complications that ensue from these lenses will allow a better understanding of their origin and thus their resolution. So expansion of use of these lenses depends on the increased knowledge of lens fitting, and management and patient will benefit from this knowledge expansion. Thank you.
Thank you, Dr. Raghav, for telling us what can go wrong and how to manage these complications. So we are open for the questions, if any. Thank you very much for the time, and I would like to thank all my co-authors to make this IC successful here. Thank you very much.